And therefore, it is not surprising that ICU outcomes have improved because of improved management of sepsis. We have recognized that respiratory distress or respiratory failure in cancer patients has multiple causes, and it's once you identify the mechanism of respiratory distress and respiratory failure, identify the cause, it is easier to treat. And it is, of course, infection is very, very prominent, and you can get all sorts of infections, including bacterial and mycoplasma, but also opportunistic infections like PCP and fungal infections. But there are many other causes like, of course, aspiration pneumonia, sepsis, ARDS, but you can get tumor emboli. You can get diffuse alveolar hemorrhage because of either because of thrombocytopenia or other mechanisms. Pulmonary leukostasis in patients with leukemia. So with the hyperleukocytosis, the white cells infiltrate the lung and actually cause hypoxia. And lysis of these cells can also cause a respiratory distress. Lymphangitis, which is an advanced sort of form, treatment related because of drugs like bleomycin, busulfan, all trans-retinoic acid and radiation. And of course, embolism, pulmonary thromboembolism is not uncommon at all in patients with cancer. So once you have identified the causes, the treatments come up, and many of these conditions are actually treatable. And not only do we know that there are now multiple mechanisms of respiratory failure, but we have diagnostic strategies to help us diagnose these conditions, right? And these are non-invasive strategies, and based on non-invasive diagnostic tests, we can pick up uh, rare, opportunistic, and previously difficult to diagnose infections with modern molecular diagnostics. You can pick up uh, organisms such as pneumocystis and mycoplasma, legionella, viruses, fungi, and so on, right? So it is now possible to uh, diagnose the cause of respiratory infection and respiratory failure much more accurately and non-invasively. There is no need to do repeated bronchoscopies or lung biopsies or needle aspiration biopsies in these patients. So our diagnostic techniques and diagnostic strategy has improved, which leads to better treatment. At one stage, it was believed that non-invasive ventilation would help patients with immunosuppressed conditions. And this was a landmark paper which was published many years ago. A small number of immunosuppressed patients, a large number of them had hematological malignancies and neutropenia, and they found that patients with non-invasive ventilation actually did much better compared to those who received endotracheal intubation. And for many years, non-invasive ventilation became the norm for neutropenic or immunosuppressed patients. And in a way, it was good, but actually, in some ways, it was detrimental because non-invasive ventilation was overused. Patients were not intubated in time. And when a randomized control trial was actually done, it was found there was no difference in outcome when you gave oxygen or non-invasive ventilation in immunocompromised patients with acute respiratory failure. You had objective criteria for intubating patients. When you had that sort of thing, then there was no difference, right? So, and possibly in some instances, we were giving too much non-invasive ventilation and intubating patient, delaying intubation where it should have been done. And maybe that's was making a difference. So non-invasive ventilation is good, and it's probably very doable and should be done, but the limit of non-invasive ventilation must be known, and patients should be intubated at the right time.